Hi, everyone. Thanks for joining us today. My name is Dr. Brooke Messer, and I'm joined by my colleagues, Drs. Mitch Eibach and Travis Witt, and we're from Vance Thompson Vision. So now we've talked a little bit about detecting early and the importance of understanding that keratoconus can look differently on many different presentations. So now we're going to talk a little bit about management options for keratoconus, particularly in the way of stabilizing the disease and treating it with epithelium off corneal collagen cross-linking. Travis, will you talk me through, the cross-linking procedure and what happens to the cornea with treatment?
Yeah, of course. So I'll kind of walk you through how I talk to my patients about it. I tell them that the procedure itself is painless, that they're numb through the entire process. We gently remove the very outer surface, the epithelial layer from the cornea, basically just giving us access to allowing that riboflavin, that vitamin drop to penetrate into the depth of the cornea. So the first half hour is where we're basically placing a drop of riboflavin, which is just a concentrated dose of vitamin B2 onto the cornea and allowing this to penetrate into the depth of the cornea. At which point then we use a specific wavelength of UV light that then targets that cornea and disperses light across it that lasts for another half hour, that then creates these bonds and allows that riboflavin to create covalent bonds within the cornea and bind to the rest of the collagen. Once the light's done, the procedure's over, they obviously have an epi defect at that point, and we place a soft bandage contact lens on the eye that stays in day and night for the patient, and typically takes about 4 or 5 days for that epithelial tissue to complete back to closure.
Yeah, perfect. Mitch, when you talk about patients who are eligible or indicated for cross-linking, who are you selecting and who do you identify as best candidates?
Yeah. And so in the FDA clinical trials, cross-linking was studied on patients age 14 to 65. I always will make the disclaimer that doesn't mean that we shouldn't cross-link a 12-year-old or a 9-year-old. That patient's at a much higher risk for progressing, but that is what we would call off-label. We do off-label stuff all the time. It's also, cross-linking was FDA approved for progressive keratoconus and refractive surgery ectasia. And so listed out here, Brooke, you have what the FDA definitions are. And I always tell my colleagues it's important to note that we're not doing anything wrong if we're cross-linking a patient who technically we haven't jumped through the hoops of progression for. In fact, if it was my 10-year-old child, that's what I would want. But insurance requirements for a lot of our insurance carriers do mandate progression and have some different definitions for that. And so a refraction change, a myopic spherical equivalent increase of greater than a half diopter, greater than 1 diopter astigmatic or cylinder increase in their glasses prescription, greater than 1 diopter Kmax or keratometry increase. And that can really be from any keratometry measurement. And so very commonly that will come from a auto K, and then now in our practice, maybe a tomography, and that can work. And then also a change in the back optical zone radius of curvature on a hard contact lens. And if I'm looking for that one, I call you Brooke.
Yes, and that's fine because I don't even look for that one that much anymore. You shared this case with me on what progressive keratoconus can look like. And so would you talk through your case for us?
Yeah, so this was a 17-year-old who came to see us in 2015. And so as Brooke mentioned at the onset, in the very early part of my career here in Sioux Falls, we were an enrollment site for the FDA clinical trial, but this was in between finishing enrollment for the FDA clinical trial and before FDA approval. And so this patient came to see us and we didn't have an option for cross-linking. We're kind of in an in-between phase. On the left, you see the first tomography here. And so I think, hard to dispute that this is a keratoconic patient. We have anterior elevation or topographic changes in that top left map. We definitely have an underlying bulging to the posterior float. We have a thin corneal pachymetry. The inferior to superior ratio is 3.3. And so what we did with this patient is said, hey, we want to see you back in 4 to 6 months. Patient that came back probably 9 to 12 months later here, and this is what we had just 9 to 12 months later. And so steepening to Kmax, almost 5 diopters. we had further thinning to the pachymetry and worsening of that inferior to superior ratio, or the cone had advanced more. And so this was a patient who definitely qualified for progressive keratoconus here.
And when you're looking at progressive keratoconus, and how does age fit into the discussion of, are you progressing or not, or help you make the decision on whether or not to recommend cross-linking?
Yeah, I think it is a misconception or a miss to say because my patient is 45, they're not progressing, or they're 55, so they're not progressing, or even if they're 65, they're definitely not progressing, because I've seen progression in each of those three tiers in our practice. Now, it's more in the 45-year-olds than it is in the 55-year-olds, and the least in the 65-year-olds. Cornea is one of the few spots in our body that actually strengthens over time. Our body creates these corneal crosslinks as we age, but it doesn't mean just because you have a certain number of candles on your birthday cake, you haven't progressed. And so we've cross-linked a 67-year-old here in Sioux Falls. She was an aggressive eye rubber, came in for cataract surgery, had a very minimal amount of lens change. We diagnosed her with keratoconus, and she said, my vision's been changing rapidly. And so we delayed doing cataract surgery, retested or remapped her 6 months, and there was definitely change. And so I don't think age is definitive.
Travis, have you ever seen a patient that has had epithelium-off corneal cross-linking with the FDA-approved method that needed repeat cross-linking?
I have not with the epi-off study. I have with epi-on prior to the FDA's approval of cross-linking. We at my previous office in Denver had done non-FDA approved off-label epi-on, or kind of a hybrid of epi-on, epi-off cross-linking. And I've probably seen maybe 2-3 cases of that. I mean, we were doing that back in 2010. The studies, as far as what's shown how effective is cross-linking, have been out there for probably 20 years or so, as far as how long the rest of the world has had access to it. And those patients, the patients that had progression and we actually did a secondary treatment for patients that had more severe keratoconus, definitely thinner. They're more advanced on that scale, and they're in that 4 to 5 severity scale.
Mm-hmm.
And had told these patients, like, we're trying to do this to avoid a corneal transplant. And if it was my eye, this is what I would do. I would definitely do cross-linking. You definitely have a higher potential that maybe this is too far along and that we won't get that stability, that there's not going to be enough tissue within the cornea to stabilize it. But I've actually yet to see a patient progress with epi-off cross-linking. Or I'm sorry, yes, epi-off cross-linking.
Epi-off, yep. And I would agree with that. And so does the data. We recently had access to the 10-year results to the cross-linking pivotal trial. And as you can see in these here, across all patient populations, which includes keratoconus and post-LASIK ectasia, 84% of patients maintained or gained best spectacle visual acuity, with 100% of keratoconus patients maintaining their acuity or seeing better. And when it comes to keratoconus, when it comes to max keratometry findings in both the keratoconus and post-LASIK ectasia group, we see a nice chunk of these patients maintaining their corneal findings, if not have a little bit of flattening. Some of the patients in the FDA trial showed actually some max K flattening in the keratoconus group. So 81% or over 81% of our patients with keratoconus actually have stable or flatter max Ks 10 years after cross-linking. So again, your experience matches that data in that epithelium off cross-linking works. And I actually had a patient once ask me, like, if my collagen turns over and I get new fibers, like, do those bonds persist? And I think we can confidently tell our patients that, yeah, like 10 years post study, we still have some really good data around its continued stability. And so now we're going to talk a little bit about the patient post-op experience. And if Travis, I'm going to have you continue your discussion on how do patients do post-operatively?
Yeah. So I tell them, once you leave the clinic, you're probably not going to like us here for a few days. That we've created an epithelial defect. We've created a scratch on your cornea. We've done it with intention and with reason, but you're going to have light sensitivity, tearing, swelling, foreign body sensation. It's manageable. It's short term. Most patients after day 2, day 3 are starting to feel like they've turned the corner. And typically downtime is, in that kind of 3 to 4 day range. I tell them you can plan to go back to work after 4 or 5 days. But that the first few days, you're going to feel like kind of laying low and kind of managing that discomfort. Vision's definitely going to be blurry for the first handful of weeks, and that again, that epithelial remodeling process is important from a visual standpoint. So we're going to create more blur. These patients come in with a complaint of blur. They have keratoconus. That's why that's why they're in our chairs, that we're going to make it a little worse temporarily. But that over time, as that epithelial tissue remodels, as it tightens, vision can return back to its state. And that's where it's different patient to patient. I kind of tell them blur's expected for about 1 to 3 months. Most patients are feeling like they're getting kind of back to normal, close to that 3 to 4 week mark. And we're monitoring along the way for anyone who co-manages with corneal cross-linking. That kind of day 4 to day 5 visit is where we're looking at, is the epithelial tissue closed, removing that contact lens at that point. At that 1 month visit, you're looking for any potential corneal haze or scarring. Some of these patients can have a response to haze and may require an increased dosage of the steroid drop at that point, or kind of a longer taper with the steroid to reduce that, just to make sure that vision continues to improve. And typically by that kind of 3 to 6 month mark, patients are starting to find that kind of normalization of vision, and that this has a potential to change their prescription as well. So even though we're not doing any corneal reshaping like LASIK or PRK in conjunction with this, as those bonds are created, they can have small changes in their Ks and therefore small changes in prescription, and a new pair of glasses or new contacts could be pursued depending on kind of what the patient's wanting at that 3 to 6 month mark.
Yeah, long term, you're kind of just resuming that normal care, yearly topographies, continuing to counsel on eye rubbing, and, managing them refractively, whether it's glasses or contact lenses. And so thanks for that nice in-depth review. Travis mentioned epithelial remodeling after corneal cross-linking and how it can affect patients' refractive error. And they sometimes have to kind of hang in there for a little while so they can get back into their traditional methods of vision correction. I think the process of epithelial remodeling is really fascinating. Mitch, could you take us in on a little deep dive on how this happens and what it means for the patient experience?
Yeah, so with epi-off cross-linking, the surgeon's creating an 8 to 9 millimeter epi defect, and our epithelium is going to heal from the outside in. So from the limbus to the center, once those cells touch together, they kind of stack on top of each other. And so that's the epithelial remodeling. And so what I tell colleagues is, if you do an anterior elevation map, like a topography at 3 months or sometimes even 6 months, it often looks worse. It looks like this patient's steepening, and it's actually just the epithelium is bunched up and kind of flattens back down over time.
Yeah, the epithelium actually masks the cone in the beginning. So it, kind of gets thicker at the base, thinner at the apex. So the cone actually looks less than what it truly is. And when that new epithelium grows back, it kind of grows back in a uniform thickness. Mm-hmm. And then, like you said, it kind of flattens at the apex and kind of hides the cone at the base. And this is a patient of mine that preoperatively, you can see his Kmax was 65.7. 6 months, he was still kind of struggling with his glasses and irregular astigmatism. And it would make sense because his Kmax had increased to 68.2. But then by 10 months, he actually came back down to that 65.2 Kmax. And he was finding himself, much more comfortable in his glasses and soft contact lenses, which we eventually fit into sclerals. But long story short is, over the process, you actually see that epithelium reshape and kind of find that unique thickness across the corneal surface to help the patient get back to their sort of expected or normal refraction and level of irregular astigmatism.